Are we live? Yes.
Yeah. Good morning, Krishna. It's Tom here. Just to confirm, we are now live.
Thank you, Tom, and good morning, everybody, and welcome to our Integrated Care Board meeting in public for Herefordshire and Worcestershire NHS. Really pleased to have a really full board today, but we do have some apologies from colleagues. So Will Taylor, Paul Robinson, Nigel Fraser, Mark Dutton, and Tracy Cotterill. And Sarah, I think you need to leave around 11, don't you, Sarah? So we'll note that as well. But otherwise, welcome to everybody. And we have got a pretty full agenda to get through. And we also welcome Francis, who's here instead of Russell today as a participant. And I don't think there's anything else. Have I covered all the apologies, Hannah? I think I have, haven't I?
You have. We just also welcome Emily Godfrey and Nicola Mallion to present papers in lieu of Mark Dutton.
Yes, welcome Emily and Nicola. So we'll move on then to declarations of interest. We are quorate. Are there any items that colleagues wish to declare an interest in relation to? We obviously have our register publicly available, but this is just the specific items on the agenda. No, okay, I'll take that as no. I will just mention, I don't think there is a conflict of interest, but in the item relating to delegation of specialised acute and mental health services, two trusts that I chair are mentioned as lead providers in those contracts, but they're in the East Midlands, so I don't think there's any conflict of interest, Hannah, but I thought for transparency I should just make people aware of that. Okay, so we move on to item 4, which is our governance log, including the board forward plan. We have one outstanding action, but that's not due until May. So unless there's anything else, Hannah, on that you wanted to draw our attention to, I don't propose to linger on that. So we move on to the minutes of the previous meeting, which was held on the 15th of January. And I just need to check with colleagues whether they're happy to approve those minutes. Are there any points of accuracy? No, everyone content, so I'll take it that we're happy to approve. So we move on to our patient and public voice. We have no questions from the public today, but obviously do welcome very much any members of the public who are observing us today, and indeed welcome questions in the future should you wish to submit any. Which you can do through our website. So I'm really pleased today that the theme for our board and the spotlight later will be on our staff survey results. And so today we have a people story, and I'm going to ask our Chief People Officer, Katie Hartwright, to introduce that for us. Thank you, Katie.
Thank you, Chair. So today's staff story comes from the perspective of a student, Maya, who joined the Royal College of Nursing's King's Nursing Cadet Programme. And then we'll also hear from the Heart of Worcestershire College in Redditch, who run the education portion of that programme. So by way of background, the Nursing Cadet Programme is designed to encourage young people aged 16 to 25 to pursue a career in nursing. And it's one of the ways in which we are working with education providers to grow the pipeline of substantive nurses coming into our system. The programme provides 40 hours of extracurricular education for cadets, as well as 20 hours of work experience with a provider organisation. The cohort in which Maya participated was funded with system development monies, with support from the nursing and midwifery faculty. Worcester Acute Hospital provided the work experience opportunity, and Redditch was determined to be the area targeted to pilot the programme with the intention of supporting students from an underrepresented area of the system. So Maya says, I am 18 years old and a health and social care student who aims to have a career in healthcare and improve lives through evidence-based practice. I entered the programme to gain a further insight into the health and social care setting, as well as seeing in real life how professionals promote the 6 C's and work as part of a multidisciplinary team. I began my placement at the Alexandra on the 20th of January 2025, and this was after we'd done college work, preparing us for the placement from October to December. The NHS staff member who came into the college was really lovely and taught us about CPR and the basic rules around healthcare. She shared loads of lovely stories with us about her past experiences in healthcare, and it made me really excited. When we went for training on the Monday, the staff were really welcoming. They took the time to speak to us all and help me through the task as I did not understand it. They were bubbly people and I learnt a lot about nursing that day. During my actual placement at the hospital, I experienced a lot of emotions as it was all new to me. I was really nervous. On my first day, a healthcare assistant welcomed me and she was showing me how the beds were made, how to feed someone and how to sort a wash bowl out. I was then sat on a chair in the middle of the room talking to all the patients. I asked a few questions, but the nurses were very busy and I was worried about getting in the way. The experience did allow me to gain relevant knowledge on the procedures that happen on a ward and how the professionals work together to carry this out seamlessly. I took away the fact that communication within the hospital is key to make sure all individual care needs are met. I know now that this is what I want to do, and my future plans are to go to uni and complete a nursing degree to enable me to chase my dream. And the Heart of Worcestershire College said, the scheme has been nothing short of inspirational to students and staff. The ability to work in collaboration with the NHS staff on the roles our students wish to progress into has brought their career horizons closer to home. Key links have been made within local NHS departments as well as the RCN. The scheme has provided the college, staff and learners with valuable insight into the challenges within the health sector. It's emboldened our determination to run a T-level in health and health science. Together, through this project, we've increased the number of learners likely to work in their local health and care social care sector. In doing so, they and we know we will improve the lives of the communities around them and respond to the workforce strategy challenges NHS partners face, a mission we all rise to. Finally, Chair, it's worth noting that His Majesty King Charles is the royal patron of the RCN scheme and last week personally celebrated the 1000th cadet participating in the scheme, and 2 of our system cadets were invited to London to celebrate with the King. Thank you.
Lovely. Thank you very much, Katie. What a great way to, very uplifting story to start our meeting. So thank you for sharing that. I'll open it out to colleagues for comments or questions at this stage. I'm sure we'll pick up sort of the broader themes about staff engagement and retention in our later item. Vicky?
I think just the same as you said, Chair, very inspirational, Katie, to start the meeting. I guess the key bit for us as a system is how we would roll that out and how we also would make sure that that experience is as positive as was described in your story. So I guess just interested in what the discussions are across the system in terms of that rollout.
Thank you. Yeah, Kath might want to come in on this from a nursing and midwifery faculty perspective, because that's where they're overseeing what we're doing. But we're certainly hoping to do another cohort and look to roll that out further across the system. I know that some of the other trusts are interested, certainly primary care are interested in some of it as well. So it's been really positive. In terms of ensuring that we provide positive experience, it's essential, isn't it? Because the experience that people have on those wards will make all the difference as to what they choose to do. So making sure we've got people around who can support them when they're there and can take the time to educate people and train them is really important. And that's the kind of conversation that's going on at the moment.
Great. Thank you, Katie.
Thank you.
Thank you. Stephen, please.
Yeah, just a brief point. I think it's a really good story. I think the other bit we need to do is link it to kind of our work around inequality and life chances as well, because I think if we really target this in certain schools, colleges that we know, we can make a double impact. Actually, we get a workforce that's really committed and we can have a real improvement in people's kind of life chances and economic kind of improvement in the patch. I think it's important we capture that as part of as we roll it out.
Yeah, thank you, Stephen. We were really happy that we'd done this with Redditch because that was targeted to do exactly that. But I think we could do much more of it. It's worked really, really well. And thank you to your trust for hosting that cohort. That was great.
Thank you. And I actually, it was the point that I sort of first noted. I think you started your presentation on the story, Katie, with a comment around the sort of attracting people from perhaps an underrepresented area of our places, and that felt really important. And I wrote down anchor institution because that's really what sort of is the message, isn't it? That we can, we're such important organisations in our ability to give those chances to people in our communities and help those particularly parts of our community that might be underrepresented. So it's a really good example and one definitely to build on. So really welcome that focus and Stephen's comment on that. Catherine, please.
Yeah, I just want to come back and from Katie's reference there. So I'm really proud to be the chair of the nursing and midwifery faculty. We've got a really engaged group of members from trusts, from primary care, from our higher education institutions, and our further education institutions. And it's been great to see this kind of start to be thought of as an idea, working with the RCN and coming through. And absolutely, Stephen, we planned some of this in around thinking about health inequalities. We worked with public health and worked on like sort of where were the areas that we would target to try and think about that, and even thinking about schools and things that we're doing. So I'm really pleased, and thank you so much, Katie, for telling the story so powerfully. It's absolutely fantastic seeing these things in action, and this is one of a number of priorities that we've worked on and we've had oversight in the nursing midwifery faculty. So thank you.
Yeah, this really illustrates our grow our own discussions that we've been having, doesn't it? So a really great story. So thank you, Katie. If there's nothing else, I know you're going to be coming back in to do the spotlight item on staff survey, but a great story to start our meeting today, and thank you for that. Yes, move on now to the next section of our agenda. So over to Simon for the Chief Executive Officer report, please.
Thank you, Krishni. As I was saying to some of you before the call started, we wrote all these papers in very good faith last Tuesday. They were all published bang on time on Wednesday afternoon, as we always try and do. And then by Wednesday night, there's a whole load of new announcements, and the world and the context in which we operate is going to change. I think we're still digesting those, I think, as a team, and we will have time to digest all of that as a board and what it means. We're not unused, are we, in the NHS to organisational change and structural change. It looks like we'll be going through a period where that will be a big backdrop over the next 6 to 9 to 12 months, I expect. The only message I've given to staff, and I think it's worth repeating here at board, is it's really important we focus on the day job. We've got a lot to do. There's a lot of really good work going on. The report as written that you can see in front of you describes the usual massive range of efforts that goes in across such a huge breadth of areas. We're going to talk in a little while about planning. We've got to get the right operational plan for 25-26. We've got to get a financial plan that is affordable and within the allocation we're given. That's all significant day job work, and we must keep the focus on that. So change will be happening around us. Change will bring opportunity as well, because it always brings opportunities to work differently and to improve elements of the operating model. But here and now, in the middle of March, heading into April, we've got a lot of work to do, and it's really important we keep that focus, really. So I just thought it worth starting my introduction. None of that is featured in the board paper, and that just shows what can happen in 6 days or whatever, where that spans between the publication and the actual meeting. But really important focus that we need to have on the day job. In terms of the report itself, you'll see pages 1 and 2 describe we're just coming to the end of 24-25, and actually I think if you take a few steps back, 24-25 has been a really quite a successful year for this system. We've had our challenges. There are things that have not gone exactly as we would have liked to do, but on the whole we've seen real progress in some of the main headline areas, so particularly elective care, waiting list reductions, particularly cancer care waiting list and outcome improvements, and particularly actually in recent months since the last board meeting, urgent care performance as well, which has always been a challenge, particularly in the Worcestershire side of our system. and we've had a really good 7 or 8 weeks actually, and people deserve credit for that. It shows that some of the things that we've been doing and the things that we talk about here at board are working and having an impact. And when we add to that, Nicola will present the finance report, and we are on track at this stage of the financial year, deep into month 11. We are on track collectively to deliver our system control total and financial plan, which, if I'm honest, I think puts us probably in a minority of systems across the country. We should be really proud of some of the things that we're managing to achieve and affect together as a team and as a system. So a good introduction to the report that describes where some of those indicators are. Secondly, I would draw out the Building a Sustainable Future programme, which we've talked about here before. We'd always intended this as a medium and longer term focus on the transformation that we needed to undertake to make the system really, really viable and sustainable financially and operationally and in quality terms moving forward. All of this is going to need to continue, whatever the structures and the plans around how we organise ourselves. We've got to have that medium and longer term focus. We've started with the Building a Sustainable Future work. I'm chairing the programme board. We've met once already. The second meeting is next week. We had a really good clinical engagement session at Worcester Warriors, where from right across the 3 trusts, the 2 counties and council and primary care colleagues, a really vibrant, energetic discussion around what's possible. And what matters now is that we take some of that energy and move it forward. And it's a great example actually of we don't need to be distracted by any organisational change. What we're doing is the right stuff to be doing. We need to push that forward, and we will fully intend to do so. And then just to finish as well, on page 7, just worth noting, Worcestershire Acute Hospitals Trust have had undertakings from NHS England that they've carried around with them for several years now. You will see that 4 of the undertakings have been removed officially and formally, and that's actually quite a significant endorsement of the progress that's been made. There's 1 undertaking remaining around sustainable urgent care performance improvement, and our intention, I'm sure, and Stephen might want to come in, is that we would move to get that removed as well during the course of the next 12 months. But actually real and tangible evidence of the progress that's been made in that organisation, that NHS England no longer feels it necessary to have those formal legal undertakings assigned. So finally, Christiane, on the final page of the report, just worth noting, Ellen Rule has been appointed as the permanent Chief Executive of Herefordshire and Worcestershire Health and Care Trust. Obviously, we welcome Ellen to the system. She'll be starting at the beginning of May. I've had a few really good conversations with her, really excited to working with her and to what she's going to bring to the system as well. So happy to answer questions, Christiane, on any of those items or anything else that's in the report.
Thank you very much, Simon, and certainly want to echo your comments, particularly in sort of in the light of, you know, some of the recent developments, just to really reflect and recognise the efforts of partners and colleagues in working, you know, in the ICB and across the system in delivering some of those improvements, which we really should appreciate and enjoy. There's always more work to do, as Simon has said, and it needs our ongoing focus despite some of the changing things going on in the background, but really well done to everybody. So welcome any comments or questions on the specific points in the report. So first of all, Roy, please.
Thanks, Chair, and thanks, Simon. Yeah, I think the report's generally positive reading, isn't it? And I guess that's sort of with last week's announcement is frustrating, because it feels like we are starting to get to a good place and then it's all going to change. I guess it is about the wider change. I know we're only starting to understand that, but I feel we were starting to get a really good sense of how we were going to tackle things like inequalities in our system and some of that prevention focus. And how can we ensure that as we sort of have a narrowed focus, I guess, how can we ensure that those things which are probably going to save us, you know, in the next few years, don't get diluted by the on-the-day pressures and the firefighting of today? How can we keep that focus?
Yeah, look, I think that's a really good question, Roy, and it will be interesting just to see, particularly in the 10-year plan that will emerge later this spring, summer, just what focus there is on inequality and prevention. I would say my view's been consistent throughout, that the strongest, there's loads of moral arguments around why we should do work in this area. But the strongest and most powerful arguments are economic, actually, that there are interventions that we need to make with cohorts within our population that are interventions that have a big economic payoff. So i.e. they really reduce and avoid future costs down the line. So I think whatever operating model, in whatever form that we end up with it through this latest change, the focus on the economic necessity of some of the intervention and preventative work will be essential. I think there'll probably be a greater role for providers. It's one of the things I know Russell and Glenn have included within the Foundation Group of Trust strategy, that they own that prevention work. They want all of the secondary care services to have a focus on prevention. And I suspect that's where this will go next, that actually every team in every service is thinking about the preventative actions they can take. But you're right, and the board should be continuing to challenge that we've got the right focus and we retain the right focus on that, because it is really important.
Thanks, thanks, Simon, and thanks, Roy, for the question. I think there were still very clear messages, certainly to Simon and I, as part of sort of a leaders event last week that we were at. That I think, and Mark was there as well. That prevention remained and left shift and all of the things that we've been talking about are really important. So I came away with a real sense that, if anything, some of the immediate improvements that are needed, particularly around the finances, were sort of actually seen to link together. So if anything, I still came away with a very clear sense of that if we are leaner but focus on things that really matter, and that does include prevention and left shift and health inequalities, then all of that should come together. So I certainly didn't see any weakening of that intent, but as we await further information, hopefully it will be a greater clarity on roles more than anything else that we will get out of this latest development. Stephen, please.
Yeah, I just wanted to come back in on that as well and kind of really support Simon's view there about the role of providers and our leadership in that. I think this is the next evolution is for us to really step into that space. And I think, talking for Worcester Acute, I think as we're getting through some of we mentioned the undertakings, as we're starting to work through that, I think we're in a better place to lift our heads up. Our staff, you see them lifting their heads up. But I think that's going to be the real challenge for us as provider leaders, is we've got to step into it and we've got to make it important. We say it, we've got to deliver it. That's the next bit for me, I think, Roy.
Thanks, Stephen. Thank you. Jane?
On a similar note, I think that's probably the most important message that we're going to give and receive today. Clear focus around urgent care, waiting list reduction and the money over the next year. Absolutely clear that those are the three big things we have to deliver, but that doesn't mean that we will lose focus, and certainly won't lose organisational focus and place-based focus on those long-term things, because we really lose the plot if we don't continue to focus on those things. So again, just an assurance that just because they're not on the top 3 nationally doesn't mean that they're not on our top 4 locally.
Absolutely. So really important that we continue to do the right things, which I think is what everybody's articulating, and ultimately I think Darcy, if Darcy is the backdrop, the Darcy review was the backdrop, it's very clear that our collective effort is ultimately about improving the health of the nation, because it was very clear that we are not as healthy as we were before, and therefore we really need to be addressing that. So I think that it's great to restate our commitment to that, because ultimately those ambitions around population health are really important. Are there any other questions that anyone wants to ask? No? Okay. Simon, you won't be surprised. I'm not going to let you off a question from me, but you may not be able to answer this one. But I just wanted to explore this and see what clarity we're going to be getting around this. It was just about the GP contract, the GMS contract, which I think is referenced in your report. Going underneath a little bit, I think one of the areas that's probably that's not received a huge amount of attention, but will need to be addressed, is this issue about people with learning disabilities and serious mental illness not being, the requirements within the contract not being the same. And I think you won't be surprised, that concerns me, because if we're serious about health inequalities, people with serious mental illness and people with learning disabilities do experience significant health inequalities in terms of life expectancy. So I just wondered if there's any clarity about how we're going to manage that differently if actually we're not registering people with learning disabilities through the GMS contract, for example.
Yeah, gosh, that's a very detailed question, Chair. Good
I
to
know.
meet you. It's very specific. I mean, I don't know any of the fine detail of that. I don't know whether Roy would know anything in addition. All I would say is there is a lot of like additional commissioning activity that happens around this cohort of patients. So, for instance, the focus we've had on annual health checks for people with learning disabilities, which are a big part of assessing their needs. This system actually has been one of the, I think we've been the top performer in the country for the last few years. So it's something we're really good at. Quite how that ties in with the actual GMS contractual responsibilities, I haven't picked up a change in this area, but maybe go to Roy. Maybe Roy might know a bit more.
Yeah, thank you. I think, I mean, Rob's put his hand up as well. It's just, I think the NHS Confeds Mental Health Network has been highlighting this. I don't know whether Rob's picked up on that, but so I think the expectation is that there will be some requirement to continue some of these things, but it's just the how is less clear. So shall I just bring Roy, in case you can add something to it, and I'm sure Rob will want to as well.
Yeah, thanks. I think there is a real commitment locally to, as Simon says, we have some of the best figures in the country for LD and our mental health checks. So, and there's a real commitment to continue that. In fact, we're working with public health colleagues on exploring some of the outcomes from the seriously mental ill health checks, and also some of the inequalities in that, looking at deprivation and who's attending and what age group. So there's a real sort of, I think, a real commitment to continue. We have had additional funding for higher targets in the learning disabilities and the serious mental ill patients, but I think technically what's coming out of the QOF contract is just the maintenance of the registers, but in some ways we have to do that anyway. So I'm confident the work will continue, and actually there's a real commitment to expand on it, and I think really look at the inequalities behind some of those health checks. So I think locally, yeah, I would be confident there shouldn't be a big difference.
Thank you, Roy. That's really helpful. Rob, did you want to comment?
It was the same point, really, Krishni. Clearly, we all hold the same concerns, but it was the point Roy was making. I think my understanding was this was more about some technical tidying up of bureaucracy in terms of registers you have to hold, as opposed to what you need to work through and deliver within the actual QOF itself. So I think it was in that context, but clearly something to keep an eye on and see how it plays out.
Thank you, Rob. That's very reassuring. Catherine, please.
Thanks, Chair. This was hotly sort of discussed at the Senior Responsible Officer for Learning Disabilities and Autism for this system, and hotly discussed, particularly around the changes and the focus. And I would completely agree. And we actually took the regional team to visit Roy's practice, where they've gone ahead of time and have got digital flags in place to make sure that we're identifying and we're treating and we're preventing at the earliest point. So I think there's an absolute commitment within the system to continue doing that, and some really strong voices from Health Watch and across the system that we need to keep on doing that. So I'm absolutely aligned with what Rob and Roy are saying, a real commitment in our system to take that forward. And that doesn't go with we'll be implementing the reasonable adjustment digital flag, which we are working through at the minute. And obviously we've got some trailblazing sites as well for that. So absolutely, as I see it.
Thank you, really helpful. Simon?
Yeah, just to finish the discussion and to take a step back or two, this is exactly the type of scenario where kind of our GP and primary care infrastructure comes into their own. In lots of areas, there will be arguing about all the fine details of the contractual change. In areas like ours, with strong, high-performing general practice, they actually, as Roy said, well, of course, they want to maintain a register because that's their way of offering good care and understanding people's needs. It doesn't necessarily need to be in QOF or the detail of the contract for really high-performing GP practices to want to do it. And actually, I'd be pretty confident that Roy's articulation would be a relatively consistent one right across Herefordshire and Worcestershire. So we spend a lot of time, don't we, discussing the strategic focus on general practice. And actually, this is one of the areas that is a great example of why that pays off over the long term.
Excellent. Thank you very much. So I think that's really helpful because certainly I think there was a little bit of kind of perhaps confusion as to what it meant in practice, and so certainly helpful to hear that assurance from different quarters, and also, Simon, as you say, because of the work we've already done within the system in this area, it's great that we can build on that. So thank you very much. I think, Simon, you were just asking us to note this report at this stage, and obviously you gave us a verbal update on sort of the other developments that have happened since the report was published as well. So thank you very much for that. We move on then to the planning update. Warm welcome to Emily, who's going to be presenting this for us today. And I think, Emily, you've got some slides. Yeah, over to you then.
I have, yes. Thank you very much, Krishni. And hi, everybody. I'm Emily Godfrey, Director of Planning here at the ICB. And today I'm going to take you through an update on where we are in terms of developing our 25-26 operational plans across Herefordshire and Worcestershire. So this presentation will cover a number of areas. I'll start off by doing a little bit of background and context. We are just a week over now when we have to submit our operational plans. So I'll take you through where we've come to and what we've got to do over the next week or so. I'll also take you through the oversight and assurance piece, which is important for us as prior to submission of our plans. Krishni and Simon will be signing off what's called a board assurance framework for the operational plans, and the purpose of this is to provide assurance that all the considerations around finance, workforce and activity have been addressed, ensuring that all the ambitions that are set out in the plan are met, and also the quality of patient care is also prioritised. I'll then take you through each of the 4 key sections of the operational plans, which is finance, productivity, workforce and performance, and then I will set out the detail to get us from where we are today through to our final plan submission, which is next Thursday. So just in terms of the kind of background and the context, so the planning guidance was released slightly later than we'd anticipated at the end of January this year. For us, operational planning is a year-long programme of work. So for us, it didn't matter when the planning guidance was released. We'd already commenced the work early last year. And I think for me, something helpful that was delivered as part of the planning guidance for this year was a set of productivity and efficiency packs based on national benchmarking for each of the providers and the ICB, and has really supported us in developing our operational plans this year. And I'll take you through some of the level of opportunity and ambition that we've got as a system around productivity and efficiency. In terms of So in terms of the headline submission, so we were asked as part of our plans to submit headline plans back on the 26th of February. This consisted of three main parts, which covered a headline financial position as at the end of February, what's called a headline checklist, and this covered both productivity opportunities that were being targeted in 25-26 and a supporting narrative around the performance ambitions as well. We then had a third document, which was our operational planning submission, which consisted of our headline workforce plans and headline key performance metrics. We then have to, as I said, submit our final plans next Thursday on the 27th of March. So just in terms of then the oversight and assurance, so looking at this through three different lenses. In terms of the board, we've engaged with the board, with yourselves throughout 24-25 as we've been building our plans, our operational plans for 25-26. This has been through the development of the medium-term financial framework, which is nestled as part of our medium-term our planning framework as well, including a session around benefits realisation and the framework that we have across the system to make sure that for each intervention that we have in place, we understand the benefits that we are releasing. Also discussion around the productivity and efficiency packs that we've had by provider and a deep dive into some of those earlier this year. And as Simon mentioned at the beginning, then the ownership of the board of our Building a Sustainable Future programme, which underpins both the plans for this year as we move into 25-26, but also that medium term and that longer term for us as a system, and how we're going to build that sustainable future. In terms of then system engagement, again, because planning for us is all year, the system engagement again is all year round. Just wanted to draw out a few areas. So the work that the financial community's done around building our medium term financial framework, and then recognising that with the medium term financial framework, the importance of engaging with our operational teams and clinical teams to make sure that we can deliver what we set out in that framework, which that generated then a workshop that we had back in November of last year, where we brought together our clinical, operational, financial and strategic leaders across the system, developed a set of design principles that we would all sign up to and work to, which underpins our Building a Sustainable Future programme. And then from there came our clinical engagement workshop that Simon mentioned earlier as well. And the key for that workshop was really getting our clinicians together from across primary care, secondary care, community, colleagues from the local authorities, that public health and social care, and really drilling down what's the problem that we are trying to solve and how collectively are we going to work together to do that. So the outputs from that then again underpins our Building a Sustainable Future. Moving on then to the kind of the nuts and bolts of operational planning and getting the plans over the line. We've had over the last three weeks a number of executive meetings with the providers and the ICB, and that's to go through. We went through our headline plans, looking at the credibility of those plans, looking at the actions that we needed to put in place to get us to a point where we're in a position to submit our final plans next week. And we've done that over the last 3 weeks. Had meetings with each of the executive teams, which has been really powerful in terms of making sure that we're all on the same page and we're driving forward the actions that we need to take forward. If I then just walk you through each of the four aspects of then operational planning, going through what the national requirement is and then what work we're doing as a system. So from a finance point of view, the national requirement then is to break even after the application of the deficit support. As we've discussed already, renewed focus on the allocation, living within the budgets that we've been allocated, a real focus on the productivity and efficiency gains, using the packs that we've been supplied with by NHS England, and making sure that we're working through every opportunity from a productivity and efficiency point of view. I think we recognise as well the potential change to the financial methodologies moving forward, for example, potentially the removal of the deficit support, and therefore our medium-term financial framework and the importance of that to get to a break-even position. So we're continuing to work around delivering the break-even position for next year in readiness for submission of our plans, re-reviewing again our opportunities from a productivity and efficiency point of view, the ongoing review again of bank and agency and substantive reductions across all sectors, and then a focus on where we've got some multi-organisation system initiatives at a system or a place point of view. So looking at driving down our length of stay to reduce costs within urgent and emergency care, and then through an elective reform lens, looking at identifying our top 3 services and where we can deliver them in a networked way, and really maximising the use of our surgical hubs to ensure that we are future proofing for any demand, again underpinned by our Building a Sustainable Future programme. Moving then on to productivity. So again, the national requirement for us was to forensically review each of the productivity and efficiency packs by each of the organisations. And there's a table here that sets out for each of the provider organisations and the ICB the level of opportunity from each of these packs, and then an estimation of the delivery anticipated in 25-26, and you can see here the level of opportunity being targeted for next year. Ongoing work will continue around productivity, and certainly as a system, we've got a very solid basis in which we're developing this. We have a number of system-wide specialty forums using the Getting It Right First Time methodology, and we continue to look at that, drilling down at a specialty level to make sure that we're unlocking all of those areas, particularly where we benchmark less favourably compared to our peer groups. Also, the continued work across the system, an example here around the work with Health and Care Trust and Worcester Acute Trust around driving down length of stay productivity opportunities, and continuing to review our back office opportunities as well across the group. Moving then into workforce, again setting out what the national requirement is. As per the planning guidance, the reduction in agency spend was set at 30% and bank spend set at 10%. We as a system, again, when looking at the benchmarking compared to our peer groups, we've gone for a stretch target of a 40% reduction in agency, 15% reduction in bank spend, and also to scrutinise our substantive staff spend, particularly looking at the growth across support functions from April 2022, and a summary table here for each of our provider organisations in terms of meeting those national requirements. Again, work is ongoing to continually address the drivers of the use of temporary staffing, looking at fragile services, looking at how we can strengthen job planning and e-rostering, again driving down sickness through occupational health services and supporting staff with absences, and the continued collaboration of our workforce planning jointly across the system. Moving then on to the performance, so the last of the 4 aspects of our operational planning, again setting out what the key national requirements are over elective, cancer, urgent and emergency care and mental health, and then just showing here that we will be compliant across all of these key national performance metrics, and then again just setting out some of the work that we're continually doing to ensure that we've got confidence in delivering the performance. So for example, the network solutions to address the fragility of some services across Herefordshire and Worcestershire, looking at things like patient initiated follow-up to allow releasing capacity in outpatients across the providers, and continuing to look at that benchmarking, look at where we've got opportunities to push further around length of stay, again to support the performance ambitions in our operational plans. So the final slide then just sets out the key activities over the next 6 days that takes us from today through to next Thursday. So today we're expecting all of the final triangulated provider plans to submitted to us, and that will be accompanied by the provider board assurance framework signing up to the kind of the governance and the delivery of the plans. We will then use the time tomorrow to triangulate the plans across workforce, activity and performance, which will then allow us to then compile a summary report and the ICB board assurance framework as well. We will then be in a position on Monday to send round to all ICB board members a summary of our operational plan, which will include finance, workforce, and performance, and also the board assurance framework, so setting out from both a governance point of view and a delivery point of view the outline of our plan. We will then allow 48 hours for ICB board members to feedback, and then final sign off by Simon and Krishni next Wednesday, ahead of full submission then to NHS England on Thursday of next week. Thank you, Krishni. That's the end of my slides.
Thank you very much, Emily. That's very clear, and we know what the timescale is very clearly from now till next week. Are you happy to take questions if there are any, Emily?
Yes, absolutely.
There might be other colleagues who need to come in as well. David?
Yes, thanks, Krishni, and thanks, Emily. It's really, really clear presentation. Thanks. You may have said this and I may have missed it, but presumably the plan we're submitting does not take into account the recent pronouncements on cost reductions at ICBs. Is that correct?
I think Simon's going to come in and answer that.
Yeah, I'll come in. It doesn't, David, because we haven't seen the detail of the timing. I did talk to Glenn Burley last week about this, and Glenn's obviously not only the chief executive of Turbat Trust, he's also now part of the national transition team. I think once there is clarity, there may well be, it's a relatively small saving in this financial year, but that may well be part of the final plan. But in the absence of any detail, it's impossible to do. So we are hoping by next week to have that, but it does depend on the national leaders kind of setting out the very clear timelines and processes.
Thanks very much. And a kind of follow-up question to that, if I may, which was, Emily, you mentioned the ICB opportunity as identified by NHSE was about 21.9 million. That feels really quite high when I look at the size of the ICB spend generally. Is that mostly coming from CHC, that 21.9?
Yeah, just shy of 20 million is the CHC, and we've got a programme of work that we've developed to deliver that full 20 million opportunity over a 3-year period, and obviously a proportion of that being delivered in 25-26.
Great, thank you very much.
Thank you. Aman, please.
Thank you, Chair. Thanks, Emily. That was a really comprehensive overview, really helpful. I just had a question around the workforce, really, particularly around the stretch targets around bank and agency, given that it's an area that we've really struggled with in the past. Just some confidence around whether we think we can get a grip on that. I know you're doing lots of things around the workforce, which you demonstrated, but just want some confidence and assurance around, can we get on top of that?
I think probably Katie, I'll ask Katie to come in and give you some of the detail around that.
And also if any colleagues, partner colleagues, because that's going to need a collective effort, isn't it, across the system. So Katie, I'll bring you in, but feel free if anyone wants to come in.
Yes, we've been, as you might expect, Aman, we've been talking at length about the assurance around that 40% and 15%. The work that's gone on across the trust, and each trust might want to speak for themselves, but the work that's gone on across the trust to put the right assurance in place has been really strong over this last year. And so there's a lot more assurance that we will do So that's not to say it's not tight. It is tight. This is a steep movement that we're going to have to make, but we are one of the highest spenders, certainly in the Midlands and even nationally. So we have to go this far, and the planning guidance this year expects us to do that 40%. That's a target that's been put on us because we are a high spender. So I'll let trust CEOs come in and say some more about that, but I feel more assured than I have in previous years.
Thank you, Katie. Jane?
Yeah, so most of this is on nurses and doctors. On the nursing side, there's two elements to it. One is around recruitment and retention, and we're in the best position we've ever been in terms of substantively recruited nurses and retaining them well. The other part of that is around the cost of agency staff and bank staff, actually. And so we are now at the NHS cap rates for bank and agency. That's not something we've ever had before in Herefordshire, because many of our agency staff will come to us from over 100 miles away. Many will come from London because the rates of pay has been so high. So getting down to those cap rates has been a huge effort, but mainly really based on much better recruitment and retention. So very confident around nursing. For doctors, we've made less progress this year than we wanted to, but we have got the building blocks in place so that we can really deliver next year. And that's about having rotas, job plans, all of those sort of good things in place that you need to really manage that well. And instead of having rotas that have lots of gaps in them, again recruiting into those rotas. So when we come to that workforce reduction, the bank and agency work is around swapping out bank and agency into substantive. So it does make that workforce reduction a higher level to achieve, because we're already putting in more staff to get the agency and bank down. But I think a level of confidence that we are able to do the things that we've set out to do.
Thank you, Jane. Also, Stephen?
Yeah, just from our perspective, and there is a note of caution I will put in, that sometimes I think we think this is about control, and you can control your way out of it, and you don't actually tackle the underlying issue of it. So for us, we've done an awful lot of work eliminating insourcing. So actually that's where it showed in the big agency spend, but it still made a contribution because we had the ability to do that through ERF. What we're really focusing back on is core capacity, because obviously that's changed for us this year. So that's how we're thinking about that. And the other one that we're really looking at is that UEC unplanned spend. We've really got to have a substantive workforce that can do that, but we've essentially got to drive big improvements across the system in UEC. That's where we're focusing, but it's all to play for. And the last thing I think we're geared up for, we're having conversations around some of this, although I've said it's not all control, some of it is control, and we have to be prepared to really enact some of that. And that means we've got to hold our nerve and be really aware of the quality and safety risks that sit around that, but manage that effectively and properly. And we're kind of geared up for that as well. So we've got a massive opportunity, and it's the right thing to do. So we're kind of like trying to have those conversations with the colleagues.
Thank you, Stephen. Rob?
Yeah, not a huge amount to add to what Jane and Stephen said. I think it's continuing what we've done this year. So we've achieved targets for this year. It's another step down. It is more difficult because we are having to address not so much the price part, where we've made a lot of gains. It's the demand part. So I'm particularly going to echo the part Stephen was saying around collectively with partners addressing the drivers of kind of unfunded capacity. Those are the critical bits. So maybe that's slightly different to what Jane was saying in terms of a focus on price. I think it's price and demand.
Thanks, Rob. And certainly I think one of the things that struck me when I observed the Finance Committee recently, trying to think which month it was, but anyway, it was a recent month. But inevitably there is an element relating to sickness absence, isn't there, which is unplanned, and that came up, I think, as one of the factors that was particularly perhaps prevalent over the winter period as it was at the time. So I think the staff survey results in that sense are also important, because this is about retention, this is about supporting our staff to stay well in the workplace, etc. All those things contribute to sort of not using as much agency and bank spend. But yeah, really good points to hear. I think the one other thing, I think, Katie, when we've sat in the regional people board, one of the sort of conversations we've had, I think, was just about kind of that ability to, and Emily talked about triangulating the plans, and I think getting the triangulation right between activity, workforce and finance, I think that has been challenging historically, not specifically for us, but just generally, that I think that's been raised as a sort of issue. And I wondered how confident we were now that our planning processes are kind of going to allow that to happen in a way that is more, is logical, or at least makes more sense. So I don't know, Emily, whether you want to comment on that, or Katie wants to comment.
Yeah, happy to do that. I think this year as well, NHS England have further developed the triangulation tools that really allows us with each aspect of the finance, workforce and activity, for both at a provider level but also at a system level, to be able to scrutinise and do a deep dive into any area that doesn't triangulate. And it is a great tool for allowing us to do that. And we can change the parameters as well, so it suits us and our system and our demographics almost. So that's what we'll be doing. The providers have already undertaken that piece of work. We'll be then doing that tomorrow as a system, again supported by the triangulation tool. And then if there are any issues, we'll then very quickly go back to our providers to understand what's driving some of those. And it might be that it's a genuinely local nuance in terms of our plans.
Great, thank you. Are there any further comments or questions on Emily's update? Emily, are you happy to circulate the slides or get the slides circulated?
Yes, absolutely.
So everyone's kind of got the picture as it stands at the moment. And I just really wanted to say, Emily said at the beginning, this has been the guidance was unfortunately late, which is, we all understand. But thank you. Don't underestimate the amount of work that has to go in from all our partners to work together to get a plan delivered. So thank you to everybody who's obviously been involved in that process. We're not quite there yet, and we will be there hopefully next week. But I just wanted to recognise the amount of activity and effort that I'm sure everyone's put into trying to get to where we are already, and I just want to thank you for that. So thank you, Emily, and we'll, as I say, receive the slides after the meeting. So that's just for noting at this moment, because Emily's laid out the next steps in terms of sign off of the submissions. So we move on to the spotlight item that we referenced earlier, which is over to Katie, please.
Thank you, Chair. Yes, this is an opportunity for us to reflect on the 2024 NHS staff survey results. These were sent out to senior leaders in February and unembargoed for all staff on the 13th of March. So what I'll give you today is a high-level overview of where we've got to, and then some of the next steps that we're taking as teams to get into the detail of them and discuss them further. And I suppose what I would say is, much like planning, this is an ongoing process. So obviously once a year the results come out, but actually making sure that our staff are happy and feel supported and have high morale is the other side of the coin that you've just discussed there, Krishni, with the workforce plan. So we're really delighted that this year our results are very positive overall, real cause for celebration. the ICS as a whole, so I have given you a link to all of the results in the paper, and if you want to go in, there's an interactive results dashboard that you can drill into. But at very high level, our ICS results have moved from being in the bottom half or third of the Midlands up to about 4th place overall. And we've had a special mention from John Drew, the regional director, for that work. And that is testament to all of the trusts and the ICB's work in improving what they can in terms of the staff experience. So we're absolutely delighted with that. And that's not because the rest of the Midlands have moved down. They've also been going up, but we've gone quicker. And that's fantastic news. So for the ICB, we had a great response rate. We had 84% response rate, which is one of the highest compared to organisations of the same type. And that's our survey results have moved us up to 4th in the country in terms of ICBs. So there's been a lot of work internally to do that, working with staff, listening to where the issues were, drilling into last year's results, and creating both local and organisational wide plans that are then triangulated across our staff council and across our inclusion network as well. For the Health and Care Trust, really good response rates for a trust of the size, so 52% response rate there, and that's really starting to see some of the transformation work come through, and that those listening exercises, bringing the work on within that trust, and some really good results around people understanding their responsibilities, which was one of the areas that I know that the trust were tackling as a result of the transformation work, and also higher than average on improved relationships. Worcester Acute have had a brilliant year. They've gone from a 31% response rate to a 46%, I think, and are the second most improved trust in the country, which is fantastic. Fantastic news, and I think really speaks to the values work that's been going on across the trust. There's been a lot of work doing listening exercises with staff and really tackling the things that people are concerned about, and I think that's a brilliant result. And then in Wye Valley, already doing well last year. You were really happy, weren't you, Jane, with your results from last year, and they've improved again this year, so you're above average for all results. And I know you've got particular strong points on working flexibly. And across the foundation trust, foundation group, there's a lot of good results around learning, so a big focus on learning and training and working together on that. That doesn't mean there's not loads to do still, and there's always things to do, but we put ourselves in a very firm position for whatever comes next, and obviously we're going to need to contextualize whatever comes next. So the conversations that we need to have with staff next will need to be had in the context of the news that we've recently received. But we know there are some things we'll be able to do together. So the way it will work now is that everybody's going back out to their teams with their results and talking through what that means locally and on the ground, and people are coming up with their own sets of local results by directorates and then bringing those up to organisational level, and we all take roughly the same approach for that. And then we come back together as a people group, and we do that through the people board and through the Great Place to Work subgroup, and talk through where we can work together on some of the things that will get the biggest bang for their buck if we were to do it collectively. We know that appraisals is one of the areas that people are going to need to do more on. For example, there's lots around people understanding their purpose and then really linking that purpose to their objectives, and then their ongoing monthly conversations about how they're getting on. And we also know there's a lot to do around disability and supporting colleagues with a disability and supporting colleagues who come from an ethnic minority background. It is still true in our results, as it is across the NHS, that if you come from one of those backgrounds, you are likely to have a less good experience compared to a white able-bodied peer. And obviously we don't want that to be the case. So we are working together collectively across the system on things like our active bystander training. And we have just agreed across the system to all use the health passport, which will support colleagues in moving their health, any reasonable adjustments that they need, or any particular support that they need if they move around the system. That will be honoured wherever they go. So we know that colleagues will be more supported in the future. So I think those are probably the headlines I draw out, and I'll leave more time for conversation. Clearly, CEO Trust will want to say things about the work that they're doing, and rightly be very proud of those results. But I think this speaks to the work that the trust teams have done, that we've done in the ICB, that we should all be very proud of, and we'll continue to build on it for the coming year. Thank you.
Thank you very much, Katie. It's another really good news story, isn't it? That everybody has improved, and that is, you know, so important for all the reasons we've already alluded to. Vicky, please.
Thank you. I think, as Chair just said, Katie, really positive results, which is fantastic. You referenced the system-wide health passport. Is that at an early stage, or have we been able to test that out in terms of actually how it practically works and the requirements for individuals moving organisations? Has that worked in practice?
We're still at the stage of agreeing. So Worcester Acute were the original authors of the document, but it has been taken into the system and made so that anybody can pick it up and use it, insert their own logo and use it that way. Everybody's agreed to sign up to that, and we've started using it, but we've not done deep testing on it yet. We can let you know as we do.
Lovely, thank you.
Thank you. Mark, please.
Thank you, Krishni. I just wanted to make that what is probably the obvious point is that all the work that's going on, notably within the 3 provider trusts here today, because as you've indicated, things are all moving in the right direction. It's not about, at its heart, about getting better survey results, although that's nice. It's about getting the best and better patient care, because there is no doubt that the better the survey results you have, the more highly motivated your teams are, the more their well-being's looked after, which means there's a correlation between that and the job that they do at the front line and give better care and patient experience. And that's what the driving force is. And I know, you know, obviously speaking for my own trust, but I suspect it's very much similar for the 2 acutes as well.
Yeah, thank you, Mark. I think there's lots of evidence to say. I think Michael West's work very clearly showed that you know, high engagement from staff actually does make a real difference to patient care, and so it's a really important connection that we need to make. And so this is something that we absolutely all recognise is important to invest in, and it's great that we've all been able to do that so successfully and measurably, which I think is great. The staff surveys is the way in which we measure that engagement in a consistent way, and so it does allow us to compare, which is really helpful. Roy, please.
Thanks, Chair. Thanks, Katie. Yeah, really positive results. It was the general practice staff are now part of this survey on a voluntary basis. And you may not know the answer, but I know at the moment the results are not published as part of this work, but is there a plan for that, and is there work we can do sort of locally? It'd just be interesting to compare how general practice staff are feeling in comparison. I think one of the practice managers from Worcestershire did some work on how staff sort of survey results compared, and we did share our results, so there may be some work. It'd just be something that we perhaps haven't looked at before.
Yeah, thank you, Roy. Yeah, sorry, Katie, before you can, I wrote down primary care because I thought, oh, I want, you know, what's the status? Because actually we were able to comment on what was happening within the councils and all of that, and it seemed like that was the area that perhaps needed further understanding. So good, really good and important question from Roy. So Katie?
Yes, we are awaiting those results. I don't have a date yet. I've asked the team to chase up on that, but we will be going through those results in a future TWIG, which is the primary care meeting that we hold on a monthly basis once they become available, and then we'll draw that into the broader system conversation, because obviously we want to be able to do a compare and contrast across the board and look for those ways in which we can work together. So absolutely, it's not fallen off our radar.
Great, thanks.
Great, thank you. And Sarah, please.
Thanks. You touched on it, and I think absolutely fabulous results, but you did mention a few particular groups where we see less good results, and it was just a comment really on the strength of any networks we've got within the organisations and the system to support people whose own experience may not reflect some of the real positivity we see in the survey.
Yeah, we've got some really strong networks. So at system level, Dr. Luke Simons runs our EDI and inclusion networks, and each of the trusts also have those sorts of networks. So we bring those together to bring the conversation into one place and work out what we can do together. It's an area that we've decided to work on together because there's so much that could be done, and actually it's the same work across the board. So the team that have brought together the EDI strategy are now looking through the results, and we'll work through what the activities and interventions need to be for this coming year, and that will then form part of the system-wide people plan. But the networks are in a good place for that.
Thanks, Katie. And do you want to say anything on the EDI front? Because obviously you kind of liaise and take a lead on that with Luke as well, don't you, from an ICB perspective?
Yeah, and that, yeah, you know, and I can say, you know, things like the health ability passport and all of that, that's all happened because of the system-wide working, and I think Luke's been quite instrumental in that. So I'm quite confident that you know, things are moving in the right direction. Certainly since I've been chairing the EDI group in the ICB, I've seen a lot of change and a lot of positive impact. And Sarah, just to reassure you, I think we are listening to staff, and the networks are really an important part of the EDI group that I chair as well. So we do rely on them quite heavily, actually, to give us input and guide us in terms of what we should and shouldn't be doing, so that we're putting in the right interventions for them, not what we think we should be doing. So I'm quite confident that we're doing that.
Thank you, Jane.
Yeah, just a final point to say, but I mean, obviously we're really pleased with what we've got. The detail's really important, because actually down in the survey, you know, there's some things which are fantastic, some things that we need to make more progress on. But I want to come back to your point, Krishni, on linking this to sickness levels. And you know, we know across the NHS sickness levels are much higher, in fact public sector are much higher than we generally see in the private sector. By staff group there is significant differences in sickness levels. And one of the areas I think from a system point of view, Katie, would be really good to focus on, which brings in primary care, is around moving to a fit note rather than a sick note culture. I mean, it's there, it's available to us, but actually on a day-to-day basis, that isn't what it really is being done. What's being done are people being signed off for weeks and weeks, and then there's sort of nothing the organisation can do about it, rather than what could you do in your workplace, rather than you have to be off altogether. I think a system approach to that would really help us to drive down some of those sickness levels.
Katie, do you want to come back in on that at all?
Yeah, I'm nodding furiously and saying yes, and my mute's on, so I absolutely agree with that, Jane. That's one of the areas that I know the Great Place to Work meeting is drilling right into, and as part of the workforce plans we've been talking about the need to bring down sickness for exactly the reason that you explained, Krishni. We're using too many agency members of staff to cover sick leave, and so all of these things do come together as one, don't they? So that will be an area that we will have a proper focus on, and I'll ask the team to dedicate some proper time to that too.
Great, thank you, Katie. David, please.
Yeah, it's probably just worth flagging at this point that we do run the Work Well service as a pilot, which our trust could refer into, and GPs who have any NHS member of staff approaching them requesting a fit note could also refer into that service for them. So we need to do some more promotion work around that. So Jane, Stephen, Robert, if you've got staff who you're concerned about, or your HR teams are concerned about their sickness, absence and risk in their employment, then they could be referred into. We can support them.
Thanks, David. Roy, did you want to come in? Or,
I was just going to make the same point actually about the we've got the work and health coach in our PCN. They're working really well. So yeah, definitely that could be, you know, a useful family. I think sometimes it is difficult, you know, as the a GP being asked for a sick note to have the conversation, but somebody with some time to spend around actually working about what their role is exactly what the work and health coaches can do. So I think that can really fit in well.
Right. Okay, so that sounds like an opportunity to really build on then, and develop sort of more strongly. So a really good suggestion. So thank you. So Katie, I think you just wanted to obviously, as per the title of the item, it's very much a spotlight on the results, which obviously I think were embargoed until just less than a week ago. So it's the first time we've been able to share them in public. But I think it's it's great to see the particular. I mean, obviously, always good to see people who are already doing well, like the health and care the Wye Valley, building on those results, but really good that also for Worcester Acute to be highlighted as one of the most improved, I think, in recent sort of news and analysis in HSJ, I think was really positive, and indeed the improvements, I think, at the Health and Care Trust and the ICB. So great work to everybody. We, some of that may be challenged by some of the developments that have occurred over the last week, as we've highlighted. So I think it's really important for us as leaders to maintain the focus on this and ensure that people feel supported and sort of steered through difficult changes that may face any of us at any point over the coming year. So really important foundations for us to build on, and thank you for the great work from everybody who was involved, collectively and individually. So thank you. That brings to a close our strategic update section. I think rather than go into the system quality and delivery report a little early, I'm going to suggest we take a short break there. So if we can reconvene at 5 to 11, that's 10 minutes, we'll get cracking with the rest of our agenda. So see you shortly. Thank you. Welcome back, everybody. We'll make a start with the system performance and risk section of our agenda. Mary, over to you for our quality and delivery report then, please.
And thank you, Krishni, and good morning to you all. So I'd just like to pick out the key areas of escalation from the quality and delivery report, and I will leave out areas further on in the agenda. And there is an area that the board particularly asks for about diagnostics, so I'll pick up on that as well. Okay, so in our children and young people, probably our highest risk related to performance at the moment, you can see the numbers of children and young people waiting longer than 52 weeks is over 3,000 children now we have in our system, largely confined to Worcestershire. And largely confined to the neurodiversity pathway. There's a national picture on this, as I've said before, but we obviously are subject to an improvement notice in Worcestershire, which means they're looking to see that we make quick improvements. The recovery plan and the investment we made today isn't having the impact that we anticipated it would. So the partnership in Worcestershire is reforming to look at what we can do to speed up the pace of improvement for those children. And increase the capacity that we need, because the demand is still growing ongoingly. But we do anticipate it's going to be a 2-year recovery plan unless we can find a wide range of providers that can quickly undertake assessments, and that's proving challenging. So I'll keep QRD informed on that and obviously report through to board, but the improvement notice means that we're subject to a lot of scrutiny, meetings, etc. from the national team to see the improvements. Herefordshire has made some significant improvements with the resource that they had, and we want to see that identified in Worcestershire as well. So we'll keep board informed on that. Elective care. So we're coming to the end of the year, and obviously one of the key targets that we had was patients waiting over 65 weeks to get to 0 for the end of March. We're predicting, there's a few days left to go, we're predicting that we're going to be around 60 patients, and that's across 2 specialties. There's still work going on daily across the trust, and I have to say, working with the trust, there is a lot of rigour around this to make sure that we are getting that number down by the end of the month. But that we benchmark very well across the region if that position is maintained, and we are then on trajectory to get to 0 by the end of April, subject to any other risks being identified. So that's positive for us. And you can see outlined the specialties that are of longer term concern about how we get back down to 18 weeks in our system. For cancer services, I'll just highlight we're doing very well on the early diagnostic, the faster diagnostic standard, but we are having some challenges in the treatment pathway for cancer across our system, largely due to surgical capacity and a couple of specialties that are bringing that 62-day cancer standard down from where it was previously. There is recovery plans in place for all of that. It just needs to be embedded and sustained, and there's a good plan for next year to get us to deliver those standards as per the operating plan. So we envisage that will improve. Diagnostics, you can see our position against the diagnostics tests. The national target of 85%, we're currently at 82.9, and we were in December. That's a good position for us. We've been in far more difficult positions in the future. There's a couple of areas, audiology and urodynamics, that we're particularly focusing on, but they are starting to see improvements as well. One of the things the board asked us a question a few months ago was, how do we know we've got the right capacity in place for diagnostics across our system? So it is a work in progress currently. The dynamics change all the time. There's new diagnostic tests nationally. There's refined diagnostic tests. We've had community diagnostic centres put into our system. The one in Hereford is due to be open this summer, subject to some issues at the moment. And we're forward thinking about, trying to forecast what will be coming into our system in future diagnostic tests. So we're doing a demand and capacity piece of work across the ICS that will be complete at the end of Q1, and we'll bring that through the QRD process so we can see where we believe there are issues. I mean, we are still trying to prepare for a CDC, Community Diagnostic Centre 3. We don't know if that will be in part of the national plan this year, but we are preparing for if and when that could happen, where that would be and how it would function, how it would meet that demand coming through. So we'll update the board when we finalise that demand and capacity piece of work. On a positive note, then, mental health, children, young people accessing mental health services, a key thing in the media nowadays. That's, you know, a real issue for all of us, really. We have an improved position on the number of children, young people accessing mental health services across our ICS, and particularly in perinatal mental health services have demonstrated good improvement as well in our system. So, you know, whilst we're just watching, make sure that's sustained, and we're putting investment in the right place to make sure that's sustained, that is really positive for our system at the moment. So those are the things I'd like to highlight from the report, and then myself and Kath will take any questions on the remainder of the report.
Thank you, Mary. Any questions or comments? Mark, please.
Thank you, Krishni. What wasn't a question, it was to give some assurance around the children's waiting lists in Worcestershire. Basically, it is a focus within the trust, obviously in association with their ICB colleagues, but just some context maybe of use in that neurodivergent referrals since 2019, i.e. pre-pandemic, have increased by 450% in that time frame, which gives you some context as to the difficulties we and colleagues within the ICB are struggling to try and address those waiting lists, but it is a focus.
Thank you, Mark. And Mary, I think that sort of significant increase in referrals or requirements or demand has been evident across the country, hasn't it? That's a national picture.
It has across the country. It's slightly higher in Herefordshire actually than it is in Worcestershire, but it is a national picture, definitely.
Yeah, thank you, Mary. And thank you, Mark. Jane, please.
I mean, that level of demand increase is it's difficult to get your head around, isn't it? So are we doing anything on thresholds and diverting referrals elsewhere, because it doesn't really compute, does it, that we've had that amount of increase in real demand? It's a change in behaviour, it seems to me.
Mary?
Thank you, Jane. I sit in meetings and ask exactly the same question. Why is this happening? There's a national dynamic on this. There's a local dynamic. So the national dynamic is I'm told there's more awareness of these conditions, and there is social media is driving a lot of that awareness. And there's a lot of requests through to primary care. I'm sure our primary care colleagues would agree, from parents asking for assessments. It's become a main driver in our system. The national view at the moment is they are looking at this to understand not so much thresholds, but how this can be managed at the lowest level within communities. And the balanced approach from some of our therapy staff about getting into schools, getting into nurseries, how we can manage the needs rather than having the diagnosis. I've never seen referrals rate any other NHS service go up like this in my whole career, and it's impossible to manage. So there is a national. We're waiting. It wasn't in the operating plan, obviously. We're waiting for something else nationally to come down to us. But the pressure to improve at a rate from both the public and the regulators is quite significant.
There's a sense here of just medicalising things that should never be medicalised, and of course what it stops then is the people who are really in need being seen quickly enough. And so yeah, just a comment.
I'm not sure it needs to be a consultant-led service to diagnose either. I think there's other ways of doing this as well.
Which is the importance of sort of looking at the model, isn't it, Mary, to manage the demand in the short term. Paul, please.
Thank you, Christine. Thank you, Mary. I'm conscious we probably went through this in some detail at the development session we had last month, and I think the figures were presented then were quite startling and stand out. Not just kind of the in year, but the cumulative impact over time that was forecasted, which I think where Mary's getting to. So you wouldn't be surprised that, yes, we are interested in what the 2-year plan really means. And I suppose getting to the root cause here, not wanting to repeat some of those things that have been said, particularly about Jane. Is this about funding? Is it about capacity, or is it all of the things come together? And I was mindful of your comment, Mary, about it's almost impossible to manage. That's not a situation that any of us want to be in. So how do we move from impossible into kind of a more considered and managed approach? So we are clear about whether it's funding capacity or thresholds are too low, or all of the above. I suppose the reality isn't going to go away.
Yeah, thanks, Paul. Mary, shall I just bring Stephen in, and then maybe you can respond to that as well. Stephen?
Yeah, I think just a couple of observations. It would be really good, Mary, to think how we maybe widen the people that are around that, because we're definitely seeing an impact in our consultant paediatric work. It's like a lot of things, isn't it? It knocks on to all over. And I think the other bit is how it may be being done, but I think previous experience of this for me is where education are as well, because quite often the need for a diagnosis is driven by that's how you get educational support for some of these children. So I think there's a bit of we have to do both together to try and tackle it. I think otherwise one part of the system would be working against the other, and it's a joint solution. But if there's anything we can help with, we'll be interested to do that.
Yeah, thank you, Stephen. Back to you, Mary.
Thanks, Stephen. Yeah, we can have a discussion about that. I think it would be helpful to get your support on this. Education are a key partner in this. They have their challenges as well. They bring them to the table. Yes, there is quite a referral rate from schools, but it's more from parents, to be honest, at the moment, that referrals are coming in. So that is a challenge for us. The situation, if the referral rate continues to rise in the next 5 years, as it has in the last 5 years, that's where this becomes very challenging. And that's where the national people are trying to understand what we can do differently. And the view is, let's do more in localities and communities to support children and families, which we need to see the detail of what that means. But I think that would be helpful for us, rather than trying to medicalise it, whoever said that, and centralise it. It's a very challenging situation.
Thank you, Mary. Roy?
Yeah, thanks. I mean, it is a real issue in general practice, and I think the problem is there isn't a very good pathway around this. And in terms of thresholds, there's a self-reported scoring system that patients and parents often know what level they need to reach in order to get that. And if they're requesting referrals, it is very difficult for us to do anything other than refer. There just isn't a sort of pathway built around it. One of the things I think I mentioned at the development session is the number of patients and now parents who are asking for right to choose referrals. It's an increasing stream. So even that 400% may be an underestimate, because we're seeing almost weekly increasing numbers of parents who are not prepared to wait on the sort of local pathways, and then are going off to private providers on right to choose. So I think again that could prevent a financial challenge as that becomes more known about, and unfortunately I think some schools are encouraging parents to take that pathway rather than going through the umbrella pathway. So I think there's definitely a brewing storm with some of that.
Yeah, thank you, Roy. I mean, it's a really complex set of issues, isn't it, and a significant challenge, which I think in all our conversations it's recognised. I mean, this does need a system solution. So Mary, I think. You've sort of I know you're very well aware of that, but it clearly needs a system-wide approach, doesn't it, and partners involved, but also just a different model, which we've sort of acknowledged. But we need some national support as well, don't we, Mary? I think to help to resolve it, given that these are common challenges experienced by many systems. So it's what can we do locally ourselves, but also what support do we need? And I think that's just something we're going to need to continue to work on collectively. So, Mary, any final point you want to add on that, or you're happy to?
No, I think that's it. We'll keep the board and QRD informed about that. Thank you.
Okay, thank you, Mary. Okay, so back to you on the urgent care winter update, followed by the cancer update.
Okay, thank you. Thanks, Christine. Okay, so national position on winter, and indeed it was reflected locally. So the first half of winter was definitely the most challenging for our system and indeed nationally. And overall, we saw a 5.5% increase in demand to our emergency departments, which we'd had that bit of that in the autumn as well. It continued in that first part of the winter. We saw substantial winter infections were seen this year. They were calling it, there was 4 infections at the same time that had considerable impact on urgent care and flow. Very gratefully, at the end of December into January, this position has significantly improved, both from an infection point of view and a demand point of view. And in fact, we're seeing demand lower than last summer, have been seeing demand lower than last summer overall. But ahead of winter, both place-based systems obviously produced their detailed winter plans, and that was aiming to mitigate the demand and capacity challenges that we normally see. And it was all aligned to national best practice urgent care and trying to improve and stabilise our performance. So from an ICS overview, so just giving a look back at winter, so seasonal vaccination campaigns, I won't go into the detail, I think we've discussed it before, but you can see positively our ICS position around for the population around vaccination campaign that we've done extremely well across the range of vaccinations. I'm well aware that the provider organisations focused hard with their staff to get staff vaccination programmes. That's had some mixed results, largely with frontline healthcare workers across our system. Better in COVID, particularly in social care, which I think social care in our system did very well for COVID vaccinations, beat the trend regionally. But obviously, there's going to be some learning for how we can improve the vaccination position in our workforce going forward as well. That was the first strand of our winter ICS plan. The second strand was primary care access. I think everyone aware on the gallery knows that we have strong primary care. We build on that to support us in winter. This year, that's been in the form of same-day urgent care hubs across our system. That's giving more access for same-day appointments when people may choose to go to the ED department or wait till out of hours to get access care when inevitably they will probably be sent to the ED at some point. So they started early in the winter. They were all operational by December. They've really started to embed in the last couple of months. And you can see there's 2 ways of measuring this for us. One is our GP appointments across the region per head of population. The table at the top of page 4 shows you we're benchmarking very well for that. And recently, I'm sure we'll want to come in this. For January, the Office of National Health Insight Survey showed that Hereford and Worcestershire ICB was the best in the country from a patient's perspective for access to urgent care, to appointments in their system. So our strategy has always been, let's keep primary care strong, let's keep access to it as good as possible, and that seems to be working. There's always room for improvement, we know that, and indeed across our 3 EDs, we've done an audit, a 2-day audit in each ED. We finalised the Worcestershire one, we're just trying to finalise the Herefordshire one, and it is showing some room for improvement that we'll bring back into the urgent care system as well. And happy to share that with anyone that would like to see that. It's interesting reading. The third big strand was having a single point of access in place for each of our place-based systems. They have really started to mature this winter. They've really started to embed. They're to give professionals access to alternative pathways rather than the ED. So be that WMAS, our West Midlands Ambulance Service, who should be calling there before they convey people to hospital to access alternative pathways. NHS 111, the same, really embedding that into our single point of access to, again, use alternative pathways. And for our GPs to access, not to send to ED, but to send to alternative pathways in the hospital, the same day emergency care. We are starting to see some real benefit from that. The region have picked this up. We're being asked to showcase what we're doing on that. And both of these single point of accesses have got further developments they want to do into next year to continue to improve, which is really positive to see. And that's all about getting patients in the right place at the right time for their care rather than the ED. So just some of the specifics, I'm just picking up the highlights here. So for Worcestershire, there's been a significant improvement to the operational oversight within the hospital, particularly focused on those long overnight ambulance delays, which apart from very, very rarely have now been eradicated, which is really positive to see. We've talked long and hard at meetings about having a streaming service away from the ED at the front door. There is now what's called, affectionately called, a pit stop in place. Got to think of a better name for this, Stephen. A pit stop in place, which the ambulances stop before they get to the ED when there's not a significant emergency, and trying to access alternative pathways, which is really, really helpful. And again, is being picked up regionally as a good practice, and it's really starting to help us. We need to we consistently delivered the complex discharge pathway performance, but we know we need to do more work on discharge to assess in Worcestershire. That's one area that's being focused on currently. And during the winter, I think we're all aware now that Worcestershire has been placed in Tier 1 classification for urgent care with a national oversight. We've had the first couple of meetings with them. There's 3 areas of focus, there's only 3 areas of focus for Worcestershire they want to work with us on. And we'll be meeting with the chief execs periodically just to monitor progress. But it was a positive meeting with them, and they're sending ESIS to work with us on those 3 areas. In Herefordshire, reductions to acute trust length of stay is one of the big areas, and maximising the better care funding in Herefordshire, and continue to develop the frailty virtual wards, those alternatives to ED as well, and there's some financial resource allocated to those schemes as well. So the impact, the first part of winter, we saw significantly compromised performance, but the last 8-9 weeks, I think it is now, we've seen some key improvements, and you can see listed on page 5 those key improvements, which for this system I'd suggest is very significant. I don't think I've ever seen that level of improvement in a period of time before, which is really great for our patients and also for our staff as well, because it's a difficult situation when it's constant pressure. I think the areas of focus going forward are going to be the EAS, the Emergency Access Standard, getting that improvement and continuing to improve on that as per the operating plan, and patients spending a long time in our ED departments. Those over 12 hours in the ED departments is a figure we've got to get down. So whilst this is positive, I think it's important to note that our hospitals, our 2 acute hospitals, still have extremely high bed occupancy, still undertaking actions at ward level to help flow out of the ED that we'd not want for our patients, and making sure that that the challenge ahead is about reducing that bed occupancy and getting that length of stay down by continuing to develop these plans in place. So just asking the board to note the operational challenges we had over winter and our approach to winter planning and the impact on the performance. We've already started to discuss through our ICS Urgent Care Board, a meeting again this afternoon, what about next winter? Because whilst the flu demand was higher than any prediction that we had, it did compromise us. We need to be ready with alternative actions to meet that demand if it comes through. So we'll continue through the ICS Urgent Care Board to look at that. I'm happy to take any questions, comments. Thanks, Christian.
Thank you, Mary. Any questions or comments for Mary on the urgent care for winter and indeed for next winter? Obviously a review of what's happened so far. Stephen?
Yeah, and I am unashamedly going to put my Worcester acute hat on with this one, Worcestershire acute. I think that was a really good summary, and obviously we recognise a lot of that. I think it's fair to say, so there could be an impression if you look at the 12 hours in department and the EAS, that's quite acute focus. I think it's fair to say, Mary, isn't it? I think 2 of the areas that they're going to come and work on are system issues that span community, primary care and acute. So the 2 that I think we're fairly confident, even though we haven't the letter, one will be community hospital length of stay and the other will be frailty that works across, which we know we've got the plans around. I think we're just looking to see how they can kind of work with us and improve on it. And I think the tier 1 will work, that we're not expected to get EAS to a particular level. It is they will pick a couple of metrics and say if there's sign that it's improving, that will drop us out. And the other bit I wanted to add from the visit, which I think, again, I think we could say is, we were quite unusual, and they acknowledged that, because usually when they trigger that process, performances deteriorate, and when they actually came and visited us, we were actually significantly improving. So they did recognise that that's a different situation than they normally might deal with. And I guess the prize for us there is it could be quite a quick process if we get that moving. So I think we've all kind of got to get behind the wheel of that and get it shifted.
Thank you, Stephen. Yes, I mean, I was going to ask about the 3 areas, but it's clear we're still sort of formally awaiting that assessment, aren't we? So hence we've not sort of specified those, but it sounds like there are some system opportunities there as well. So thank you, Stephen. Francis?
Thank you very much. And yes, noting the improvements, I'm sure we would all agree that we still owe an apology to many of our citizens who have a suboptimal experience through our urgent and emergency care system. And just mindful of making sure that we're treating the cause, not managing the symptoms. Of course, patients who are medically stable for discharge and don't need to be in hospital are a significant cause of delays within our emergency departments. So we in Herefordshire have seen significant improvement, particularly in pathway 1 for discharge to assess in Herefordshire. Our colleagues are well versed on some of the issues that we have with our patients who live in Wales, but all that we can do through frailty, same-day emergency care and other initiatives to avoid people coming to an acute hospital when that's not in their best interest will significantly impact on our ability to care for people in that situation who do need that appropriate care.
Thank you very much, Francis. Any other comments or questions? Mary, the only other thing I was going to ask, because I think you said the audit reports on the sort of audit. I think it was only at Worcester Acute, though. Is that right? Or was it across the system we did the audit?
The 3 ED departments we spent, I think it was 2 days in each ED department. A team went in. Roy was part of that team to look at, patients coming in, what was the alternative, what could we do, and there's 3 or 4 key findings that we'll bring back through the urgent care board and to the providers, and then we'll highlight to QRD what those are.
Yeah, and it would be great, I think, just to I mean, obviously not to see the detail, but to highlight those opportunities through into the board so that we're clear, because clearly a valuable assessment that was done, audits that were undertaken. So it's really good to get some insights from those and how we intend to take those forward. But very helpful. I think everyone said, clearly a lot of improvement, which is always good. If we're in control of our own or addressing our challenges and on top of them and demonstrating improvement before people have actually visited us, that's a really positive thing to demonstrate, but always more to do, I think, as colleagues have said, and we'll await some further clarity around the focus that they want to bring to that through that assessment process that you referred to. But really helpful, and thank you to everybody who's been involved in certainly addressing the improvements in the short term. As ever with these things, it's the sustainability of our improvements that will be really important. So thank you. So we note that update, Mary, and we move on to the cancer update then, please.
Thank you. Thanks, Christian, again. The board asked for an update on cancer referrals and where we were nationally. I think some data had shown that we were slightly out of kilter with national incidence of cancer. This is quite complex to explain, so I'm going to do my best to keep it as simple as possible. Okay. So obviously diagnosing cancer earlier and quicker is better outcomes for patients and less demanding on the health service. And we've already discussed in this meeting, haven't we, about prevention and how we can prevent cancers across our system. But cancer is evidenced with aging population as well. We do have a very high aging population in our system as well. So we did through the national benchmarking, we were slightly ahead on the diagnosis of cancer. We were 7.5% of our population against the 6% national picture. but we have the urgent suspected cancer referrals. We do, we have a lot of suspected cancer referrals coming through now, and that will give us a diagnosis of cancer if that's appropriate. The detection rate is a slightly different rate. This is detection rate that is purely from those referrals that come in from primary care through to acutes that actually show that actually result in a diagnosis of cancer. Again, we work with primary care, and primary care do very well in sending through referrals earlier for potential cancer diagnosis. We have got a much better detection rate than other areas, which is a good indication that primary care are referring early, are referring quickly for patients, and getting diagnostics done fairly quickly as well. So the long-term plan has been pushing this for a long time, and the parameters change frequently because we start new diagnostic tests, we do new campaigns. Social media is playing another big part in this as well at the moment. But I think, in fairness to our trust, they've managed this very well with the increase in demand that's been coming through. And you can see towards the bottom of page 2, the operating plan, the cancer planning pack has come through with 4 key areas, which align to what I've just said, to make sure that we continue to see that early diagnosis, and we're pushing for referrals. I think the challenge for us going forward is having the workforce and the diagnostics to meet that increased demand, which is really, really, really important for us. I think the main sort of data-driven aspect that you can get from this report is on page 5 at the top. So you can see the referrals how they've gone up since 2009, apart from COVID year, obviously. But the referrals have continued to come up through the early suspected cancer pathway, and the conversion rate has come down. So we are diagnosing early when we need to, but we're also filtering out the patients that haven't got a diagnosis by seeing them quickly and telling them that they haven't got a cancer diagnosis. There are some specialties where we do struggle slightly, so or we're struggling because there's been a national change. So the lower GI pathway, I've talked to the board before about fit testing and the age that older people are doing fit testing now. The age profile has increased. That has given us many more referrals, but largely our cancer pathways have managed that. Dermatology, I mean, even this winter we've seen a massive increase in dermatology referrals. It's normally a summer phenomenon. We've seen it this winter, and it's one of our fragile services. So we are working how we can sustain that with the use of more technology to support that going forward. So cancer incidence is due to rise. By 2040, the number of cancer cases is projected to be around 1/5, meaning that about 500,000 new cases of cancer will be diagnosed each year in the UK. So the demand is going to continue to grow, and with our ageing population, we're likely to be on the higher side of that. So our ICS Cancer Board, as part of the elected board as well, are looking at demand and capacity in each pathway going forward to make sure we have a sustainable solution to meeting this demand. So a lot of other detail in the paper. Overall, it's largely positive for us at the moment. We're referring early, our primary care is referring early, our detection rate is good, it's benchmarking well. Our ageing population is influencing this. We've now got to sustain the demand and capacity going forward to meet this future demand. Happy to take any questions, Krishna.
Thank you, Mary. Any questions then for Mary on that? Or comment? Jane, did you want to come in?
Sorry, I misclicked my hand. It might be in the report, but I was just looking for it. In terms of the early detection rate and that 75% ambition, where are we, Mary? Do you know?
I asked the question myself this morning, Jane. Just
okay.
Somebody might ask. We're at 59% at the moment for 1 and 2, which is it's actually better than I thought it was going to be. We've got a trajectory to get to 72% by 2028. So I'll be asking why we can't get to the 75%. But so we are doing fairly well. We're benchmarking fairly well on that one, definitely.
That's great. And obviously the CDCs and direct diagnostic will really help with that, won't it?
Okay, thank you, Jane. Roy, please.
Thanks, Mary. Yeah, I mean, I think sometimes the almost the low diagnostic rate is seen as a a sort of poor outcome, but actually it should be seen as the opposite. I think we are being encouraged to refer more and more patients, so we expect a lower referral rate. So I think we're seeing exactly what we should. One of the metrics that we're always interested in, and we look at in RPCN, is the number of patients admitted as an emergency with cancer. And I think sometimes there can be something, there can be learning around some of those patients about, opportunities missed. And I know the PCNs are working on, as part of the cancer direct service, around looking at some of those patients. And I think, whether we can get any system data on that, because actually that's a very almost telling statistic. If we're doing things properly, we're picking up people at an early stage, but if they're turning up as an emergency presentation to A&E, that's probably something that were there opportunities missed, and I think that's an interesting group to look at. The other question is slightly outside this paper, is just around screening data, and as PCNs we do struggle to get some of the screening information in a timely manner. Smears is easy because we do those in general practice and we have the data ourselves, but bowel cancer screening and the breast screening, we had some really excellent data from Public Health, I think about 2 years ago, where they'd done some helpful data split down by PCN, and I don't know whether that's something that could be looked at again, but we do struggle to get the screening data, and I think it's really important for us to understand where we're at with those screening programs. So, but really helpful. Thanks.
Thanks, Roy. So, Mary, I think question about so people who might be identified as needing support through urgent emergency care, as opposed to a more a sort of proactive approach, and then screening data, I think, were the two areas that we were after about.
Thanks, Krishna. Yeah, thanks, Roy. Helpful. Our detection rate is more positive than other areas. That's suggesting patients are not as many patients are going through the emergency department. But Roy, I'll find out if we can get the details of that by PCN and see if there's any way we can feed that back. And I'll chase it with Public Health on the screening data, because that is available. It is available. I'll just find a way of making sure it gets to PCN level. Okay.
Great. Thanks.
Okay. Thank you. And certainly, I think I remember I'm looking to David Mahaffey here, but I do remember going to the Health and Wellbeing Board in Herefordshire. I think it was a few months ago, wasn't it, in January, David? And I'm sure we talked about screening and some data that Public Health were collecting then, but I don't remember enough about it. And they were doing a dashboard of some kind, because I'm sure we talked about kind of the importance of screening. But David, can you remember that conversation?
Predominantly about bowel and cervical screening, and I think from my recollection of the conversation, it's focused around learning disability patients in particular.
Okay, so it was very specific, but no, and of course there was we referred, I think, to the sort of announcement nationally that they were going to use the NHS app or try and increase the amount of women who were proactively looking, getting breast screening and cervical screening, I think, was another area of focus. And Amanda made an announcement last year, I seem to recall, that there was going to be a ping and book system, which were the words that I remember, but I don't know what the timescale is for that. But yes, I'm quite pleased that I did remember that, Jane, which Jane's commented. It sort of suddenly came back to me that we were talking about screening in the Health and Wellbeing Board. But thank you very much, Mary. Really helpful. So I think there's definitely some what I'm kind of reading from that as the non-clinician here is that actually we are identifying the risks and being more proactive in terms of referrals, etc., which is leading to better detection. Is that a fair sort of layperson summary of the sort of findings from your review?
Yeah, that's exactly it, Krishna. I think our next stage is to make sure that all of the cancer pathways that you see listed here are sustainable going forward for the future, and how we can make sure that's delivered across our system is really important.
Great. Thank you very much, Mary. So we note that update, which was something we particularly were keen to have. So good to see that. So thank you. We move on then to, so in Mark's absence, I think Nicola is going to lead the item on financial plan and delivery. So over to you, Nicola.
Lovely, thank you, Chair. So sort of draw your attention to enclosure 14, which provides the board with an update on the financial position at month 10, within which it confirms that the system is continuing to report delivery of a balanced plan for 24-25. To highlight that within the report, members may note the shortfall at Wye Valley Trust against their planned efficiency delivery target and agency targets, which falls out to a year-to-date adverse variance of 8 million. And I guess the question would be, if you read that, you know, how are we going to deliver a balanced plan? So to provide assurance on the delivery of a balanced plan, the main driver of the efficiency shortfall at Wye Valley is the uncertainty around their income assumption of 6 million with regard to Welsh income. This entails Welsh commissioners paying less for their activity than an English commissioner would pay for, and therefore there's some inequity in that. This has been escalated nationally, and the national brief is that Wye Valley is expected to accrue for this at month 12, with their assurance that they'll resolve this issue. And so that and some other income expectations will mitigate this shortfall. So we continue to report at month 10 and indeed at month 11 that we will deliver a balanced position at 24-25. To highlight within the capital section of the report, it also talks about a potential 700,000 underspend against the capital resource for this year. I can confirm that there are now plans in place to absorb this, and therefore from a system perspective we are anticipating fully utilising our capital allocation. As I said, I confirm that actually for month 11, which has yet to go to Finance Committee, we are continuing to report from an assurance perspective for the board that we will hit our 24-25 balance plan. That's all I'm planning to say on the report. I'm happy to take questions. My one ask of the board is, as you can appreciate, we're approaching year end. I'd ask the board agree to the delegation of approval of our 24-25 financial accounts to be undertaken by the ICB's audit committee on behalf of the board, please. I'm happy to take any questions.
Thank you very much, Nicola. Any questions pending that decision to delegate approval? Jane.
I just have one comment, and it's sort of a bit of a public really, that so it looks like capital, and we're always saying we need more capital, and then it says, oh, we're struggling to spend it. So just some of the context around this. So our digital capital was approved a few weeks ago. So that's the money we've got for capital for digital investment for the year we're just finishing, was approved after Christmas, and so then we've got to spend it all in the last few weeks of the year. I can only hope that the changes at the top of the NHS are going to make some of these things much better, because it makes us all look not very good when we've got plans to deliver, we've got plans for things we want to spend on, and then the allocations don't come through until say the last couple of months of the year.
Thank you, Jane. I think capital has been a bit of a bugbear for a while in terms of how it's been flowing through, it would be probably fair to say. So hopefully that will improve. But I was going to ask about contingencies, Nicola, around and making sure we are utilising the capital resources. So I think you've given that already, that you're confident, or that we are confident that we can do that. So any other comments? I mean, you know, as Simon said, I think just important to remind colleagues, I know we haven't quite finished the year, we've got a few more weeks to go, and Nicola was talking about month 11, so we haven't obviously seen month 12 picture yet, but we are hopeful that we're going to, and we are currently forecasting to hit our plan, and that is that is an achievement, albeit, you know, one without, you know, it's not to say that's not been without challenge, and there will be further challenges in the coming year. But again, thank you to all partners for maintaining the focus on that, because it's really important. And good also to hear that there is some an approach we've been asked to take around the Welsh income, because that's been, I know, a question we've sort of debated in previous meetings as well. So being asked to accrue for that suggests that we can expect that to come through. So that's positive. So Nicola, thank you for the update. If there's no further questions or comments, then can I ask the board whether it's comfortable and happy to support the approval of the delegate the approval of the 24-25 accounts to the ICB Audit Committee? Everyone content to support that? Okay, thank you very much. We'll take that as a yes. Thank you, Nicola. We move on then to the governance and assurance section of our agenda. So we are item 15 is the delegation of specialised, quite a mouthful this, specialised acute and mental health learning disability and autism services. So is it Nicola again? Or
it is me again. Thank you,
yeah.
Krishni. Thank you. Just briefly, so members will recall that over the last 2 years, ICBs have taken on responsibility for the commissioning of primary care, ophthalmic and dentistry services, as well as 59 of the 79 acute specialised services commissioned by the NHS England. This year, 25-26, sees a further delegation encompassing an additional services, acute services up to 70, mental health, LD and autism. So within the papers there are 3 enclosures. One provides a briefing on the ICB's key responsibilities for these services. The second, the agreed delegation agreement, which is the legal mechanism for NHS England to delegate their responsibilities to becoming our responsibility as an ICB, and the collaboration agreement, which details how, as multiple ICBs working together, we can make joint decisions through the West and East Midlands joint committees that Simon sits on. So both the delegation and the collaboration agreement have been endorsed by the Strategic Commissioning Committee, and I would therefore ask the board to approve the signing of both the delegation and collaboration agreement, not dissimilar to last year's, between NHS England and the ICB for 25-26, please. Happy to take any questions.
Thank you, Nicola. Firstly, then, there are some questions. So Vicky first, please.
Thank you, Nicola. I think it's really just the question, going back to what Simon was saying at the beginning of the meeting, that obviously with some of the changes that have been proposed, then the ultimate accountability with NHSE, how that's going to change over time. And I know that there won't be an answer yet, but it's one thing that if we're signing today cognizant of that, then it's actually how do we consider that issue?
Yeah, thank you, Vicky. Simon, do you want to comment on that as you've put your hand up anyway?
I mean, it relates to the point I was going to make, really. I do think it's important we move forward and get this tidied up. Whatever happens in the next phase of our journey, having as much local control and influence over these package of services is going to be really, really important. It's been one of the probably frustrating elements of the last 4 or 5 years that stuff happens in this service portfolio and it doesn't bear enough of a relationship with what we're trying to do locally. So whatever we go to next, I think the most local control influence we can get over this is really important. And secondly, I also think the collaboration across our neighbouring ICBs will also be a big part of the next chapter of the journey. And this clearly is quite a big thing that we are already collaborating on, and then with the signing of this agreement we'd be planning further collaboration. So it's all in the right direction of travel from my perspective.
Okay, thank you. David, please. Oh, David, for some reason we can't hear you, even though you look like you're off mute.
I'll be double off mute
There.
now.
Yeah, that's better.
Didn't realise I got 2 mute buttons and both have to be. Yeah, thanks, Krishna. Thanks, Nicola. If I understand the papers correctly, 2 questions here. If I understand the papers correctly, there's a different governance for this new set of arrangements than there was from the past. Is that going to cause us some kind of complexity in terms of control, or is that just something that we're going to have to live with, or can we eventually bring them under one governance? And of course that relates, Simon's put his hand up, that probably relates to what Simon was saying earlier. And the second one is there any extra financial risk for us in this extra delegation?
I'll let Simon go first, unless he wants me to answer it.
Just on the governance, in essence, David, it's one committee, it's a joint committee, but with the agenda is split into a part A, which relates to these services, and a part B, which relates to the pharmacy, optometry and dental services. And that's simply because of we haven't got kind of 5 hours to spend in a meeting going through it all in one go. The meeting is split into 2 different agendas and packs. But as this all moves forward, as potentially the scope of the collaboration on these services and maybe even more increases, clearly getting the right governance will be quite important. Nicola, do you want to comment on the financial risk element?
Yes, I can do, thank you. So obviously specialised services by their very title indicates it's high risk, and that you could get a couple of patients that would blow your budget and prevent you having robust forecasting. What we have got is a risk share across the ICBs, which means actually that risk is in part diffused, mitigated. So and also we sit on the committees, and actually they've been very keen to balance the books and to stop investment. So there's always risk, but I think it'll be a managed risk, and therefore we're not overly concerned. And also proportionally, we're quite small of the element of the overall budget, so our risk is mitigated by that amount of resource that we utilise locally. So I'm not worried.
Thank you.
Okay, thank you. So if there are no further questions and comments, bearing in mind that the documents have been scrutinised by the Strategic Commissioning Committee and supported and endorsed by that committee on behalf of the board, can I confirm that the board is content to approve the signing of the delegation agreement and the collaboration agreement to start from 1st of April. Okay, thank you. So thank you very much, Nicola, for covering that off as well. We move on then to the remaining sections of our agenda, which are really over to Hannah in the first instance. We've got a committee escalation assurance report and some comments on committee effectiveness as well. So Hannah, over to you.
Okay, thank you. So before I hand over to the individual committee chairs, just wanted to highlight a couple of things from this report. So firstly, we have now completed our committee effectiveness review, and the findings of that are included on page 3. So in particular, Quality Resources and Delivery Committee, this is really quite a complex committee looking at all of the assurance for the entirety of the work the ICB does and covers. So we do usually have comments coming back in terms of remit, overlaps. I think all this is actually really good work in progress, and a lot is being done to clarify that with the various subgroups that we now have in place. There's also been a comment about including colleagues from other organisations, obviously really conscious of duplication and people's availability and time, but the door is always open on this committee, and we do various deep dives into areas of concern, and there probably is some merit in inviting colleagues from other organisations to join us for those. In terms of the Finance Committee, again, reflection of the committee is still fairly new, the Joint Finance Committee, so there are some housekeeping points that have been raised, but also sort of finding the right balance between focus on in-year assurance and longer term priorities and transformation. So all of those comments are summarised on page 3. Then the second point relates to the mental health joint committee review, which again has now been completed and lasted about 4 to 5 months. had a really fantastic input and engagement with all partners and colleagues across the system. It is summarized in some detail within the body of the whole report, but just some key things to highlight really. So first of all, the review acknowledged the importance of having a committee focus on mental health, and I think that is going to remain. I think what the recommendation has put forward is that there is a shift from operational and transactional focus into more strategic commissioning area. With that, then, a number of responsibilities which would be more transactional would be moved over to the Strategic Commissioning Committee, which is where the rest of the ICB business is currently conducted. I'm not going to go through all the recommendations, but again, another one that is probably of significance is that the review is recommending the development of a delegation maturity matrix, again recognizing this is clearly the right direction of travel, but a consensus about when is the right time for delegation and when all parties involved are ready and mature. So I'll pause here, and I'm happy to either take questions now or hand over to the committee chairs for anything that they wish to highlight.
Yeah, thank you, Hannah. So any questions for Hannah on committee effectiveness? I am conscious that a couple of committee chairs have had to step out of the meeting, so we probably won't get an update from everybody, but I'm sure if there are any questions on the content of the report, we can take those as well. So anything on what Hannah said already? If not, I'll just open it up to committee chairs if they wish to come in and comment on any aspect of their report, or members in the absence of committee chairs. So over to David, Aman or Vicky, really.
Should I kick off in terms of QRD? This obviously covers the 26th of February meeting. I'm not going to go through the content. A lot of it's been covered in today's board meeting, but I think what I would comment on is QDOS, which supports QRD, has been in place about 18 months now. Really effective and has matured significantly to give us the confidence about the issues that are escalated and enables QRD to have a very focused discussion on those areas that we really need to discuss, and hence escalate them to the board. So I'll just pause there. Happy to take any questions.
Okay, thank you. Aman or David, anything to add? Obviously, if anyone wants to ask questions, I'll welcome those.
Yeah,
anything to add?
Yeah, just we're on track in terms of the external audit, which I know we've struggled to kind of meet the deadlines previously because of the issues we've had with the current external auditors, and just that we've received a favourable draft head of internal audit opinion, which I think I'd just like to be noted, and thank everyone for all their hard work to getting us to that.
Great, thank you very much, Aman. That's great. Nothing from you, David?
No, nothing from me.
Okay, Vicky?
I think I said to Sarah that I would come in to cover SCC. Really just to comment that we've got 3 sets of highlight papers here from the January, February and March, so comprehensive suite, but nothing particularly to pull out, some of which the content has come to today's trust board.
Great, thank you, Vicky. I just really wanted to comment, and I'll bring Hannah back in anyway in case there's anything else she wants to highlight. But it was very useful to go to both the Audit Committee and the Finance Committee since the last board. So thank you for accommodating me in that. Always great to see that there were partner NEDs represented in those meetings and contributing and asking questions. So that was good. And just in terms of the reports, actually, I was really pleased to see that we'd signed off, I think, a research and innovation strategy. And I did think that that might be something that we could perhaps talk about, Hannah, in the future to development session. It might be quite nice to talk about what we're doing collectively. Not, doesn't need a huge discussion, but I think it'd be really interesting to talk about research and innovation together in a board development session, and how we're taking that forward. So I just thought, because I do think that's an important part of retention of our staff as well, because I think a lot of our clinicians will value the opportunity to be involved in that. And the other piece that I picked out, which I think I picked up before, but the work that's been done on high intensity users, I think a little bit of a project with was it the British Red Cross, I think, on that, which would be really interesting to get, because I remember almost quite early on when in a Worcestershire Executive Committee, Worcester, is it WEC, Simon, I think it was, one of my early meetings, I remember we were talking about that piece of work, and it's quite interesting, because I think this is high intensity users of our services is quite an common issue, isn't it, for a lot of systems. So I would just be interested to get a sort of small case study document or summary of the things that I think we learnt from that, because it would be good to share that with others.
I think we've got that, Krishni. I went to it's not called WEC anymore, I don't think, is it, Stephen? It's called something else. But I went last week or the week before, and there was an update on the progress. So we'll maybe weave that in, Hannah, into my report next time as a good.
Yeah, it would just be, I think it's a really good example, isn't it, of something that we've actually seen through and from the beginning. And if there's some positive evaluation, be good to share that, and then obviously share that with other colleagues or share that in the public domain, because again, it's a good example of working with the voluntary sector as well in the way that we've approached it. So thank you for that. I just wanted to highlight those things. Hannah, anything else to add? I think it's just the report is there for noting, but anything else you wanted to highlight?
No, I don't think so, Krishna. I think that's it.
Okay, thank you very much. So then back to you on corporate objectives, please, for 25-26.
Okay, thank you very much. So every year the ICB resets its corporate objectives. So naturally, given the ICB's role, these relate both to the ICB's corporate responsibility as a statutory body and that of its role as a system leader. So we've tried to, in this year's, in the setting of 25-26 objectives, we've really tried to pull that apart a little bit and sort of focus particularly in objective 1. Sort of split the focus into where the ICB has got a direct influence over achievement some of those priorities, and where it is very much a provider-led initiative or a priority. So this is an evolution of a previous year's objectives. There haven't been any drastic changes, but we have fine-tuned it slightly. We have acknowledged the interface between quality and delivery. So previously that was objective 1 and 4, and the significant duplication overlap that existed within that. And actually those two should always be in tandem and reporting very similar level of assurance. So acknowledging that, we have now combined the two into a single objective, which is now objective 1. We have also building sustainable future clearly features very importantly in the strategy for the next year. So this now forms the vast majority of objective 3, which previously was system development. We're maintaining, of course, our focus on finance, also health inequalities and prevention as objective 4, and the 5th objective then relates mainly to the ICB's role as a statutory body. So the detail, the objectives have been discussed with the board at its board development session in February, and some further comments have been received since. So thank you very much to all of those who have come back. So the final product then is included on page 3 onwards. Just should really also mention that actually, given last week's announcements, there will have to be a couple more tweaks to those priorities, obviously specifically in terms of the running costs. We do need to sharpen that up a bit, because obviously now that focus becomes something slightly different to what it was originally articulated, and also something about the reset and transition in terms of the ICB as a corporate body and the impact on staff, which would feature somewhere in objective 5. So it is a bit of an evolving piece, but once approved and agreed, we will then build our future board assurance framework on this and bring that to the board in May. So happy to take any questions and asking for a formal approval of those objectives today, please.
Thank you, Hannah. So as Hannah's highlighted, I think the board has engaged with these objectives now over a couple of, certainly a development session and also had the further opportunity to comment since then. So I think the natural question, Hannah, would have been what do the recent changes mean? And clearly you've articulated a response to that already. I think it's difficult to say any more than that at this stage, and clearly we will revisit those if we need to. But in the meantime, is the board content to just approve these, given it's been engaged with these objectives previously? So if there are no comments, I'll take that as approved. Great. Okay, thank you. And then finally, Hannah, we've got our Board Assurance Framework report, which relates to the objectives for the current year as opposed to the new objectives. As Hannah said, we will obviously refresh this for the coming year. But in the meantime, anything you want to highlight from paper 18?
Thank you. So yeah, this is the final instalment of the Board Assurance Framework for 24-25, and as such we have therefore set out for every objective and every priority where we have ended up in terms of our assurance levels. So at the start of the year we set our target assurance rating, which is informed by the risk appetite that the board agrees at the start of the year, and then we move hopefully somewhere towards where we said we would go to. So we have not managed to achieve our target level assurance in all areas, in all objectives, but I think the board has been well informed throughout the year as to why that is and what the risks are that inhibit that progress. We have, however, made significant strides in a number of areas, and that is set out again within the body of the report. And then specifically on page 7 of the report, you have got a more of a pictorial representation in terms of the priorities where we have reached the required level of assurance, where we have reached partial level of assurance, and where we have not got to where we were hoping we would. And then finally, at the end of the report is just a summary of the risk position, including a couple of risk changes, new risk open in terms of the Oliver McGowan training rates, which the board, again, I know is cited on, and also a decrease in risk score in terms of planned NHS strike action. So I'll pause here and as ever happy to take any questions.
Okay, any questions or comments for Hannah? Stephen.
Yeah, there were a couple, and I'm conscious of time, so Hannah, if you want to pick them up outline, or we pick them up. I think the first one was on the assurances that were given around the finance section. So I'm just thinking, it looks like we're saying year-end assurance is partial, but it looks like we're going to hit our plan. And then given what we know about the environment we're in for next year in the medium term, it might be we almost swap them around a little bit. And that's not in our gift. That's not that we haven't done it. It's just it's a big unknown now, isn't it, about how that's going to play out. And then my other bit was just I think there's some really helpful commentary, but it might be interesting for us to do a bit of work on where we said we were going to be significant or not and how we've ended up. And I guess the question I'm thinking in the head for a board is what was in our gift and what wasn't. So what learning do we take from that in terms of driving these things forward going on? Because some of them I can look at and think it was a demand issue, it was this, it was kind of out of it, as far as it were, a bit out of our gift, but there are somewhere I think, yeah, that might have been in our gift and we need to just learn the lessons and go a bit harder at that. So it's just something to think about, Hannah, as you go through.
Yeah, thank you, Stephen. Really good points. I think in terms of the finance one, I'll pick that up with Mark when he's back. I think it's a good point, and I think things obviously move quite quickly at the moment, so that is fine. I think in terms of the second point, I think it's really interesting. I do think sometimes we are a little bit over ambitious as well in setting our target assurance rating, and I do think we probably need to put a little bit more effort in making sure that this is realistic. I think this year the intention is, so for the April board development session, we'll be talking about risk appetite in quite some detail, and actually it would be really helpful if we can link up those two conversations and be really clear actually what it is that we are prioritizing and what we know is, like you say, within our gift and what isn't. And then perhaps we can talk about building into the board development session perhaps next February, that conversation around actually it looks like we're going to end up in this place, and what has caused us be here, and what are the factors that were within our control, and perhaps those that we then need to reset for next year. So yeah, no, thank you for that. We'll definitely factor that into the plan.
Yeah, thank you. I mean, I think they're really good points, Stephen, because I think there's it could be that we set a different ambition, or we choose to put different resources, or something else. We do something differently because we didn't achieve the aspiration we had in terms of our objective, and the learning from that is important. Otherwise, we're just going through the same process again and potentially being no further forward. So I think it would be good, Hannah, to think about whether there are any areas that we can sort of reflect on for that in that risk appetite session, and certainly make sure we build that into the discussion we have, as you've rightly said, in the year to come. So really good points and really helpful, I think, Stephen, for us as a board to think about, because this does need to be something that's adding some meaning, creating a meaningful discussion, not something we're just ticking a box on. So it's really important that we have those conversations. So can we leave that with you, Hannah, to pick up as part of the risk appetite discussion that we were planning anyway for April, and we can perhaps do some reflection on that as well. So good. Any other comments or questions? We're actually doing quite well for time, because I think we were due to finish at 12:30, but we have got ahead of ourselves. So not that I'm welcoming a vast number of comments particularly, but I did just want to say if anyone did want to come in, that's okay. But if there is nothing else, then I think, Hannah, you're just wanting us to note this report, I think, at this stage, aren't you?
Yes, it is just for assurance, so it's just for noting for the board.
Yeah, indeed, and certainly to note also the changes in risk ratings for the couple of areas highlighted, and with the follow-up that we've suggested following Stephen's prompt. So thank you, everybody. That does bring us to the end of our meeting. We've been very efficient in covering our content today, so thank you everybody for contributions, and thank you to members of the public who may be observing us, and I'll draw the meeting to a close. Thank you.
Thanks, everyone.
Thank you.